transition. Our fourth panel is Advancing Precision Mental Health, Integrating Neuroimaging, AI, and Therapeutic Innovations. This session will delve into the cutting-edge tools and treatments that are reshaping our ability to diagnose and care for patients. I'm delighted to introduce the chair for our next panel, Dr. Carolyn Rodriguez, who will guide us through this session and also introduce the panel speakers. Dr. Rodriguez is the Associate Dean for Academic Affairs at the Stanford School of Medicine and is Professor of Psychiatry and Behavioral Sciences. She directs the Stanford OCD Research Lab and leads translational, clinical, and mechanistic studies of rapid-acting treatments for OCD and other mental health conditions, including pharmacotherapies, non-invasive brain stimulation, psychotherapy, and suicide prevention interventions. Please join me in giving a warm welcome to Dr. Rodriguez.
Okay, you guys are in for a real treat in this next section. It is my pleasure to introduce your first speaker, Dr. Teddy Akiki. He is a clinical assistant professor in the Department of Psychiatry here at Stanford and associate director of computational neuroscience and AI-driven clinical translation at the Stanford Center for Precision Mental Health. He's a physician scientist, and his translational research integrates artificial intelligence, multimodal neuroimaging, and clinical neuroscience to advance precision psychiatry for a number of disorders. His work focuses on developing computational tools to map stress-related neural circuits, building AI-based neurobehavioral foundational models for treatment prediction and stratification, and conducting neuroimaging-augmented clinical trials to validate predictions and refine therapeutic strategies. As a board-certified psychiatrist, Dr. Akiki treats patients in the Stanford Translational Precision Mental Health Clinic, incorporating these emerging research advances into our clinical practice. So join me in welcoming Dr. Akiki.
Thanks so much, Carolyn. It's great to have this opportunity to speak to you all, and I look forward to the discussion session. But until then, I want to talk to you about our work on developing AI foundation models, specifically designed for neuroimaging data, with the ultimate goal of making pragmatic and useful predictions when it comes to psychiatric questions. In psychiatry, we still lean heavily on trial and error. Two different people with vastly different brain biology, vastly different symptom profiles may still get the same diagnostic label. That's often the case. And the way we approach treatment is generally based on that label and some guidelines. We take a best guess at what should be the treatment. We have no objective way of knowing beforehand whether someone's going to respond or not. So naturally, there's a lot of trial and error. It takes several cycles. As you heard from the previous speakers, it takes several cycles for someone to find a medication that works for them, if any. And I believe that we could really do better. And so the main question that's driving the work that I'm going to present today is whether we can find a robust computational tool that can help guide us in a data-driven fashion and help us refine our probability estimates for when we're trying to estimate whether someone's going to respond to a specific therapy or not. The reason why I chose to focus on the brain as the main organ where to find this signal, let's say, as opposed to a blood-based biomarker, is because, like many people in this room, I believe that the brain is the most proximal organ to psychological distress. And so I placed my bet on the brain because my assessment was if there's going to be a signal, that's where it'll likely be found first. Not that it cannot be found elsewhere, but I think we stand to find the best chance we stand is by looking at the brain directly. Now, one of the challenges is unlike neurological disorders like multiple sclerosis, where with the naked eye you could look at the brain scan and find a lesion. Pathology in psychiatry is very subtle. We think it occurs at like the microcircuitry level generally for most disorders. And so you cannot see it with the naked eye, very hard to see on structural scan. And so that's why we decided to look at function, brain function with functional MRI, which gives us a tracing for a proxy for brain metabolic activity from every region of the brain. And then we could look at how that is different in individuals with mental health difficulties. Now, another challenge that people in neuroimaging face is that generally, when you recruit people for studies, it generally goes by label. You're recruiting a cohort with MDD. And so those labels, they create a lot of heterogeneity because as I mentioned, you could have different people in the same buckets. So one solution that we found was instead of thinking of a disorder as the statistical unit, whereby you're looking at a whole sample, you could flip this and then consider the individual patient as the statistical unit. Another barrier is signal complexity. There's the brain signal is very complex, a lot going on there, high dimensional. It also has a lot of noise. And what we've been able to do over the years as a field is refine our methods and find methods that are more robust to noise and complex enough to capture those complex interactions. And finally, we have in neuroimaging, the data sets are very small by AI standards. So typically a couple of hundreds patients per data set, as opposed to the tens of thousands or hundreds of thousands that you need for typical AI applications. So thankfully, one paradigm that that you just heard about, actually, the foundation model paradigm, can be applied in this case. So by the definition of a foundation model, which was actually coined here at Stanford, is a model that's trained on broad data that can be adapted to a wide range of downstream tasks. Complicated definition. I don't even know what that means specifically, but I'll give you a good analogy. As a recent parent, what I realized was that the foundation model paradigm is very similar to raising a child. What I like to call it is let chaos learn and then write the fridge rules. Essentially, free-range child mode is a toddler experimenting around the house, falling, dropping food on the floor, discovers gravity this way. And then after that foundation, then you could intervene and post what the fridge rules are. This household, no dropping cups on the floor. Way more effective, trust me. So you've seen this at work, this paradigm at work, as previous speakers perfectly illustrated. So just to recap quickly, like a simplified version of what's going on here is there's you can think of it as being a two-step process. First step, unsupervised. You just let it do its own thing. You get a base model, which then you could fine-tune in case of large language models, let's say with question-answer pairs. That's overly simplistic, doesn't account for many of the more sophisticated things, but we could distill it to this essence. So what we set out to do was do something very similar, but for brain imaging. So essentially, our thought was, we could leverage every scan. If you'd leverage every scan that's out there, regardless of what pathology it comes from, healthy people with various mental health concerns, different scanners, different countries, anything for that first step. let the model develop, understand sort of the brain grammar, and then use our very precious but small-scale clinical data sets to do the fine-tuning step. I'll skip the slide. Now, of course, brain signals aren't language. So for fMRI, these look like time series. What we were able to do is we got inspired by the field of computational finance. Essentially, market fluctuations, so like stock market, time series have very similar properties to the functional MRI signal. And so we used some of the frameworks that those fields have developed to be able to tokenize or render the brain signal into a sort of language that we could use to train our model. And then for the unsupervised task, step one, we did a combination of three separate objectives. First objective, we gave the model brain scans from the same individual, several scans from the same individual, several scans from other individuals. We let the model figure out which ones are which ones, and it gets sort of the loss function. Essentially, it gets penalized every time it makes a wrong guess. So it's incentivized to make the right guesses. The other task that we thought would be important is to fill in the blanks. We randomly mask a brain region. We let it have access to every other brain region, and then we teach it to guess what the activity would look like in that masked region. And thirdly, temporal prediction. We give it a snapshot of brain activity, and then we have it predict what comes next, like 20 time steps into the future. And what we found is that those models, if you give them enough brain scan, they do a fantastic job. So almost perfect performance on held data when it comes to figuring out which brain scans come from the same individual. So like fingerprint level performance. Very robust performance on like fill in the blanks, as well as the future prediction, as long as it's like within 20 type steps, 20 seconds into the future. So it catches about half the signal. Now, all of that is a means to an end for us. I'm a clinician scientist by nature, interested in clinical questions. And so for me, what was interesting is step two. Now that we've gotten this head start, because we have those foundational, the model knows those foundation principles, how can we teach it something that is clinically relevant? And so we took those small scale but highly detailed data sets that we have. So these consist of imaging plus clinical information. These could be symptoms, behavioral performance on cognitive tasks, treatments, anything. And we feed them together in this like fine-tuning fashion. And what we found was that on benchmarks, this method worked really well, outperforming conventional machine learning methods that do not include this initial step one that is unsupervised. So we did this across a variety of prediction tasks, and it performs robustly on all of them, either comparing favorably or vastly exceeding the benchmark. But a more interesting question is, can these be used to forecast treatment response? So not just decode how someone's feeling right now, but how they might do on a specific medication. And so because of the vast data sets that we have in the center, we've been able to have access to a very good data set, a very large data set by neuroimaging standards. Not just for pre-training, but also for fine-tuning. So in total, 642 individual patients who've completed trials of different types of medications. So 2 SSRI, 1 SNRI, TMS, behavioral therapy, placebo. And we encoded all of that information, as well as how they did 8 weeks later on their symptom assessments. And so we're able to reformulate the question. The most relevant question, in my opinion, in the field is not what's the best drug for depression, because I don't think there's such a thing, but into what's the probability of response given this person's brain scan if I intervene with a specific treatment. And I think that that's a much more tractable question. And so what I have here is just a demo snapshot of what our prototype looks like, which we call neuro-foundational models, or affectionately neuroFOMO. So essentially, it loads the frozen model. doesn't make any changes to the training data at this point, and we're using it in inference mode on an N of 1 basis, meaning after training, we test it on a subject that it hasn't seen in its training data set. And as you can see, it can give you a not just a single probability of whether someone's going to respond or not, but it could do it based on the different treatments that we have in our training data. So for this specific example, you see that per model prediction, say venlafaxine, this person has a higher chance of responding to venlafaxine compared to, let's say, a traditional SRI like escitalopram, and that it's probably worth it to intervene because if we wait, so the placebo combined with care as usual arm was only 21%, had only a 21% response rate prediction. And so this could also tell you, perhaps some people do not require therapies and we just wait. And so it could also give us this information. Now, most importantly, whenever we come up with these models, obviously this is a very early research example. These need to be heavily tested. So everything that I showed you has been tested on several held out subsets of the data that hasn't seen during training, but that's definitely not sufficient. And for like the real test, we need to see how it performs on prospective data. So we freeze the model, we recruit new patients, we let it make its predictions, and then we see how it fares later on. We compare it to those pre-registered predictions. And we have several trials, including ASD, that follow this similar design. And at the same time, we're also working on expanding the menu of therapeutic options that we have. And so we're testing targeted therapies to be able to add these to the training data, including pramipexole reward circuitry and guanfacine for cognitive control, for the cognitive control circuit. So we'll be able to add all of these once we have enough data. And finally, translation. As my colleague Eric, the next speaker, will tell you, we've been making great progress into making a lot of these methods available to patients. So we do offer sort of functional MRI circuit assessments via our Precision Psychiatry Clinic in collaboration with radiology. So we're really excited about the trajectory that this work will take. And with that, I'd like to thank one of our collaborators, most of all our participants and patients who really motivate this work. Thank you all for listening.